Alongside the project series, I'm your host, Simran Siraj, the communications lead for AI-Sarosh. AI-Sarosh is a knowledge hub that brings together researchers, innovators, and practitioners from 8 organizations across South Asia who are building human-centered AI solutions for our health systems. Through these conversations, we try to go beyond science to understand the context, challenges, and lived realities that shape how technology is built on ground. This series aims to create regional knowledge, drawing on our shared experiences and lessons that can inform maternal health and public health across borders. Today, we're diving into a fascinating study from Sri Lanka, one that combines maternal health, large scale research, and artificial intelligence. The University of Colombo team, led by Dr. Kapila Jayaratne, is carrying out a population based cohort study in the Western province. I would like to welcome Dr. Rasika Rajapaksha and Dr. Dineshani Hettiarachchi in this episode to share their work on the maternal mental health enhancement mobile application. Thank you so much for your time, and we're very glad to have you both on this episode. To introduce the app, the Maternal Enhancement app is essentially like a digital health report that uses AI models to predict serious risks like preterm birth, low birth weight, preeclampsia, perinatal mortality, and even postpartum depression. What makes it unique is that it doesn't really stop at predictions. It also sends health alerts, timely health advices to directly to pregnant mothers and their healthcare providers. But with any innovation, especially one that promises to change how care is developed, there are important questions. How reliable are these predictions? What are the cultural and ethical considerations when we're sharing such sensitive risk information with mothers? And perhaps most importantly, what are some of the lessons that we can learn from your team, from Sri Lanka's experience, that will help shape the future of maternal and newborn health across South Asia? We'll dive right into exploring this app with our guest today. Dr. Dineshani, let's start with a broader context of the study. What motivated this large scale research? Why was the Western province chosen? And what do you think are some critical gaps in maternal and newborn health that you and your team is trying to address?
Yes, thank you, Simran. So when we look at like the South Asian data so far, Sri Lanka actually has achieved remarkable progress in terms of maternal and newborn health over the past decades. To give you some numbers, our maternal mortality ratio is down to 18 deaths per 100,000 live births, and our neonatal mortality rate is about 4.1 deaths per 1,000 live births. But unfortunately, it has stagnated and like plateaued. So what we want to look at is whether we can have some AI solutions to bring down the preventable maternal and newborn mortality rates in Sri Lanka. And to answer to your second question, why was the Western province selected? So Western province is one of the most dense, socioeconomically dense areas in Sri Lanka, and it is diverse. We have urban areas as well as rural areas as well. So the Western province covers about 54 MOH or maternal and child health units around this area. So it is a very dense and diverse population that we are targeting. We have multiple ethnic groups, wide socioeconomic differences in this region. So we thought it is, if we can implement an AI solution in this area, then it will be generalizable for the entire Sri Lanka. And to answer to your third question, why did we select this, and what are the gaps that we have identified? So far, we lack granular data and prospective data on maternal and newborn morbidity and mortality. So this study in terms motivated us to look for such data, and also to it was an opportunity for us to use AI to identify risk early and predict the adverse outcomes early, and to guide proactive interventions that can further reduce preventable deaths.
Thank you so much for that answer. It's so interesting that a certain population in Sri Lanka is so diverse, and that can then shape how healthcare is delivered across the country. My next question for you will be that in many South Asian contexts, maternal health programs often struggle because, like you said, there's fragmented data, there's late detection of any risk, and sometimes even there's not enough access to care. How do you think these realities have showed up in your research in the context of Sri Lanka, and how did it inform the design of your study?
Yes, that's a very good question, Simran, because in Sri Lanka, we have near universal coverage of antenatal care. But unfortunately, the information system is still largely paper-based. So it's fragmented across facilities. So this means while we can track broader indicators, we often miss very critical data like early signs of complications and also socioeconomic differentials, as well as we don't have this care seeking behavior in our population. So these limitations and delays in risk detection lead to a lot of inequalities in our population. So with this, we came up with the concept of Mathru health app or even the electronic medical record system, where we can digitalize and integrate this data and also give a feedback to the mothers in terms of detecting risk early and then giving that alerts to the public health midwife to take action early. So again, it is this in this context is that helped us to sort of gain momentum and sort out this app and give personalized reminders and health advice directly to the women and caregivers.
That's brilliant. I think it will bridge so many gaps, and AI will just ensure a lot of timely healthcare access to, especially to mothers who are often only going to health centers for like very late minute health problems and not really when it's early on can be detected. Before we go deeper into the intervention, I would love for you to introduce the team behind the project. You know that a study of this scale is often more than just doctors or IT engineers. There's a whole team that backs up such a large scale effort. Would you like to share what diverse skills, disciplines, or partnerships have informed your study?
Yes, so we have a set of diverse skills, as you mentioned. So we have expertise from IT side with Rasika's team, and we have Dr. Kapila is a community physician. He has a lot of expertise in this area, the maternal and newborn mortality issues. He has worked in at the grassroots level, so he has like hands-on experience in this area. So I personally am a medical geneticist, so I look at birth defects and early diagnosis of birth defects. Then we have a pediatrician, we have an obstetrician who is very hands-on with the project. So as you know, as you mentioned, it's a diverse sort of a multidisciplinary team we have developing this app.
Sounds amazing. Now that we understand a bigger picture, let's talk about the innovation. Tell us about the app, Dr. Rasika. What is it called? Why is it called that? How does it work for a pregnant mother? And what kind of information or alerts do you think this app will give? And how will healthcare providers be looped into this app?
Simran, thank you so much for the question. This app is called Mathru app. So we will call that is that familiar word for the mother. So that's what we name it like that. And then we do have actually two versions in here, not only one. Like we do have the mobile app as well as the web app. So, which for the convenience of our doctors as well as the pregnant mother, it's mostly we are encourage them to download the mobile app, which is most quite familiar with the literacy with the IT throughout the country. So basically, in this two of those electronic health record systems, which enables to data collection, which actually our research assistant team and the MOH doctors are enabled to enter the data throughout the mobile app as well as the electronic health record system of the web app. So together we are like making more feasible for our users to encounter with the data entry. And then furthermore, in this mobile app is gonna be, we can enter the data as well. So we do have like the privileges given for each of those categories. We have research assistants, and then they can enter the data, and also we control the privacy of the data. They can see only their data they entered. They cannot see the other data as well. And then we have a very big admin on the top of it, like he or she can see all the set of data. And then furthermore, our research team, the core research team, Dr. Dineshani and me, Dr. Kapila and Dr. Pandula, all of these team can view all the data and then just cross-check. And then we do have some personals in the higher level that to validate this data. We do have the validations also in this data collection, because it's very important in this kind of a context. When it comes to the data collection, we include all those. We do have like around 18 forms right now. Actually, like because we are planning to not only predict like 4 or 5, there are like our requirement from our doctors to like predicting around 15 predictions for like preeclampsia, low birth weight, and postpartum hemorrhage, all those things. It was listed down in our documentation. So in the very beginning onwards, we identify the algorithms which are outperforming for the predictions in terms of AI from throughout the other literatures. And then right now we integrated only now few. Now other rest of the algorithms are in the process of the development. Within a month, we're going to be include all the trained algorithm over there. Right now in the situation is the data coming, and then another thing I want to explain it in here about the mobile app, which is actually the kind of a product that we are getting the input from the pregnant mother. So here we concern about the pregnant mother mental satisfaction also, because that is not keep on monitoring throughout any of the health recording system. So because this app is, they can the daily mental satisfaction, and then the kick counting, and then the contraction counting, and also what is the stand on the pregnancy, how many weeks are remaining for her. And then furthermore, it was sending the alerts, which was from the AI algorithms on the back end when they were figuring out any issues. It's not going to be sent it to the our pregnant mother. It's going to be sent it to our doctors or the MOH officers, because we have to be careful with dealing with the patients, because the reason is if they were sending out a risk alert for them, then it will be a huge problem. For these are so the outputs that we are taking from the pregnant mother is the mental satisfaction in any of the inputs which shows relevance for the doctors to keep on monitoring, daily monitoring of our pregnant mother. And then in our electronic health recording web app, we do have the doctor's display. It actually based on now the trained algorithm, we are getting the data from the current pregnant mothers who having the expected delivery from December 31st onwards. So then we can actually predict whatever the adverse outcomes he or she gonna be face. Right. So then that going to be sent it to our MOH doctor, and then not going to be midwife that much, but for our assigned doctors regarding to any of the risk outcomes, and then they can take a proactive decisions to take care any of the issues going to be showed up. I think I answer all your questions. If anything is, let me know.
No, no, you've covered everything. Thank you. This sounds very brilliant and very inspiring also, since the AI models are behind this app is predicting a large number of things, like you said. I'm very curious to know if the data only comes from the pregnant mothers that we've taken like through a primary source, or are there other sources of data that are backing all of this information? And how do you ensure that there are accurate alerts that are going to these mothers? Yeah, I think that is a very curious thing that I have in mind.
Yeah, that's a very good question, Simran. So when it comes to this AI type of predictions, we mainly developing a decision support systems. These are not anything overruled from any doctors. This is like kind of a reducing the workload of the doctor, like kind of a we're gonna use the usage of the AI in order to reduce the human errors and also reduce the workload of the doctor. So that is our main intention on this. And then we right now we actually trained our model based on the existing data, which is relate. We try to match for the Sri Lankan context as much as possible. As an example, let's say we do have the Nigerian pregnant women data and also from another from Nepal, right? So we more gonna be cater to the Nepal data set because it's gonna be more suit for the South Asia. So because there are we don't have like all those 15 prediction data availability right now. So therefore we're gonna look until we cannot wait until the expected delivery and then all the data are collected. So we're going to use that existing data and train the model. Now the crucial part is to answer the question is the validation, right? So we have to validate our data. So we are not going to be enabled our prediction to our doctor until it is validated with the existing data as well as it's validated from the healthcare workers, because we have to set up some thresholds regarding to for the risk, whether it's a medium or high or low. So based after we done the proper validation, and then now the next issue is like when you have like set up a model, it gives a high accuracy. It does not mean anything because if the model is overfitted, that high accuracy will gonna gives you wrong predictions. So in here, what we planning to do is we do the proper validation schema we have. So we're going to follow it, and then further we're going to integrate and enable the prediction to our doctors. So that is the process.
Sounds very interesting. And I think it's so important. It makes me so happy to hear because being responsible with this data, and especially when we're talking about health data for pregnant mothers, it's so important to be responsible with our predictions. And you've answered my next question also. It was about false predictions that AI can possibly give, but there, with the strong validation process, I think we can always function properly with how AI can false predict if there's a validation system. So my next question will be for Dr. Dineshani. We've talked about how the app works in principle, but often implementation or even working on it on a daily basis tells a different story than theory mostly. From a mother's perspective, what do you think the adoption process for this app will be like? Do you think women will be comfortable with receiving such sensitive health predictions through their mobile phones or even through web?
Yeah, so as Dr. Dr. Rasika also mentioned, if we directly alert the patient or the mothers, they're going to be alarmed. So definitely there will be some hesitancy in taking up any form of technology in that matter, which will predict your pregnancy outcome, may it be postpartum depression or gestational diabetes. But what is important here is that the prediction goes to a healthcare worker. So it is not directly going to the mother, but it is going to a healthcare worker who can then look at the information and provide supportive care. So it is not directly going to the person. And then also, as you mentioned, we have to train the AI, we have to put validation tools. So this is just a pilot study to collect the data, after which we will probably going into phase 2, where we look at the prediction of this information.
Okay, so from my understanding, no alert is directly going to the mothers, right? It's first going to the healthcare provider and then going to the mother with a supportive system.
Exactly. That the main alerts will gonna go for the person who actually responsible. I mean, the responsible doctors, so or the midwife. So there is like the health alerts goes in different levels that it is required to send. Like let's say if there is something that we have to send it for the MOH doctor. So we're going to categorize it and then send the alert for the emerge, doctor. Sometimes the midwife does not have that much of knowledge regarding to some certain scenarios and some certain situations happens. So in that context, we're gonna send this for the main doctor regarding to the data collection to take the necessary precautions and the action. So there are several alert levels that we implement in our app. So based on the severeness uh, of the problem, so it's gonna be sent it to the relevant personnel. So and then as we said, like according to the we're not gonna be scare our midwife, or we're gonna say scare our patient. So need to be careful with that. Otherwise, because midwife does not have the doctor's skill level and the experience, so we have to be careful with those different roles. So we understand and we will keep on like communicating with our doctors and the our software development team, and then integrate what is actually very suit for the Sri Lankan context.
Thank you so much for clarifying this. I think these are great lessons to learn from your specific context, that when you're going into the community, and especially when you're giving a product that delivers care, through a phone, through a screen or something, then you have to build trust in the community. And I think, as patients, we trust what doctors say so much more than anything that anyone else or a non-doctor would tell you, for example. So I think you're doing groundbreaking work, especially at developing trust. Do you think you have learned something more through this project about how to build trust, specifically in the community in the Western province, once this get pilot tested and goes into implementation?
So what we've actually learned is trust begins with people, not actually technology. So mothers trust their midwives and the community healthcare workers. So involving them in the face of this app has been crucial. So and also it's important to give them transparency, privacy, and autonomy. So once we have all of these together, I think then the trust builds gradually. So community trust is something that we have to sort of look at building gradually. It doesn't happen overnight. So once they trust the people behind the app and trust the process, then I think it's easier to implement app like this.
100% agree with that. Moving on to our next question. Technology can often technology can often predict really accurate results, but ultimately, even there is still a human side that is delivering, that is explaining those predictions to the patient, right? So, I want to talk more about the role of midwives and frontline health workers here. How do you think you will prepare them or train them to handle such sensitive AI-driven predictions, especially in rural areas, and especially in a way that can protect their autonomy, mother's autonomy and privacy, while also ensuring trust? Do you think factors like language, literacy, like you said, there are socioeconomic barriers also? How are all of these factors contributing to your training and in pilot testing for this project when it comes to midwives and frontline workers?
Yeah, so data protection and confidentiality has to be emphasized. So any training or any sort of input into the app should make, we have to sort of give priority for data protection and confidentiality. So there are several steps, as Rasika mentioned, to ensure that the data is protected and they have their privacy, without breaching their privacy. And also, as you know, Sri Lanka is a diverse we have multi-ethnic, multilingual population. So we have Sinhala and Tamil speaking people throughout our country. So the next step would be to translate all this into Sinhala and Tamil and make it more user friendly for anyone with any cultural background. So again, making it culturally sensitive and having that local languages embedded in it will make it more usable. And also, in terms of using the midwives, it has to sort of be embedded into their existing workflow. So if this app is going to take 2 hours more of during their work working hours, it's not going to be successful. So we have to find ways of how to integrate this into what they are actually at their day-to-day activities, and how they are collecting data at the field level. So again, that is something that we will be looking at after the pilot project, and after implemented in the private pilot study, how to sort of scale it up. So in that phase, we will have to really look at how to sort of communicate to the wider Sri Lankan population, as well as how to make this app more user friendly in terms of reducing the workload on the midwife rather than adding on to their workload at the moment.
Thank you so much. I think you've raised an important point that any innovation that is coming into the healthcare world, and as AI Sarosh, we should sort of ensure and advocate that no innovation should create more burden for the healthcare staff currently, especially because these AI solutions are to simplify our work and is to provide more services in a short given time, and to maximize our resources instead of overburdening them. As we come towards the end of our conversation, I'd like us to reflect on, some bigger lessons that we've learned throughout this journey. We have been working with AI Sarosh. Your team has been working with us for over 2 years, for about 2 years now. Looking back, what do you think has been a most important lesson, or perhaps a challenge that you've encountered in conducting this cohort study, or something that has changed the course of this study over the past 2 years? And you both can answer this individually or together as you like.
Rasika, would you like to
Yeah,
go ahead, and I will answer?
sure. Okay, I will do that. So, thank you, Simran, for the question, for like these to share the experience actually. In terms of Sri Lanka, like having this AI like integrated into the healthcare system is actually, and then automation, this type of process is actually the government needed as well, because right now we are in the process of digitalizing all this stuff. So, and then other than using pen and pencils and the papers, like if you're gonna integrate such a implementation, which actually more sustainable for the entire community, and then furthermore, just AI Saros take the initiative by providing us the facilitation regarding to that. So, furthermore, like this kind of application for the data collection, and also the prediction system development, which actually helps our country to reduce the maternal problems, or the any of the child who are going to be birthed in the future, if they have a better delivery comparative to any complications. So if we able to predict these things in advance, like it will be really help for our country. And then furthermore, it was actually because of this project, actually we do have the combination with the AI and the software development team and the doctors. So that integration has done based on this project. So then, and we also keep on learning from the doctors, and as well as our doctor team also learning some of the concepts regarding to the developments as well. So it actually transferring the knowledge back and forth throughout different multidisciplinary groups. So that's one of the advantage. And then we also open up for the other South Asian countries throughout this entire project, like what they have done, and then how we can integrate that their work in ours. So we do have that interaction was developed throughout this AI-Sarosh platform. So actually that help us a lot to even improve in the medical side, as well as the improvement in our applications as well. So yeah, that's in terms of the development side. Dineshani.
Yes, so in terms of the wider application of it, I think any AI solution, especially in the healthcare system, should be inclusive, context specific, and human centered. So, how do we overcome the inequalities that it can sort of have? Because, to be honest, it should not increase the divide. It should sort of bridge the gap between the haves and the have nots, so which is a wide audience in when it comes to the Sri Lankan context. So in terms of the practical aspect of it, I think we can, even oversampling the marginalized communities will help us train the AI as well as reach to a lot of the diverse communities and make app inclusive. So I think for anyone who's starting to develop an app, especially in the South Asian community, I think it has to start with community and the health system, and we have to identify what are our limitations, especially in terms of resources, and have a really good understanding about the frontline healthcare workers. And here it is definitely the mothers' needs, because sometimes when we are sort of collecting data, what we realize is some others, they are even registered at several MOH areas. Sometimes they come for the initial visit at one area, particular area, but to deliver the baby, they go to their own hometown. So they might probably be residing at their husband's hometown, but they will be going to another hometown. So, so in that context, I mean, if we have sort of an app that can capture all the pregnant women in Sri Lanka, that will get all that data centralized, but at the moment that is not there. So it is fragmented, as I mentioned, and it is paper based. So probably we might not be able to follow up that mother in this particular study, but it is that sort of identifying that gap in our system that has enabled us to look at what we can do to sort of overcome and bridge the divide between the haves and the have-nots, as well as the different communities and the ethnic groups that are there in the Sri Lankan population.
Thank you so much, Dr. Dineshani and Dr. Rasika. I think you've both raised such important points. The non-digitization of our health records is a pertinent issue that we've noticed in our conversations from our sub-frontiers across South Asia. We've noticed a similar problem in Nepal, in Pakistan, in Bangladesh also. And like you identified, other data sets from other countries which do not share a cultural context with our South Asian context, they often do not predict and they might create more divide than unity for our solutions. So for whoever's looking to work on AI-driven maternal health tools, we need digitized data, and it is a priority for any AI tool to actually bring innovation and bring ease into our care providing services. Are there any other advices or insights that you would like to share with other scientists, researchers who are looking to tap into, maternal health and improving maternal health for people, even if they're not in Sri Lanka, but in other South Asian countries? If there's any insight or advice that you would like to share,
I think
I'm sure our people would appreciate that.
yeah, so in general, I think this is, for me, it's the first time that I've been working with a group of IT specialists. So it's a lot of trial and error, I think, because sometimes we think that, it's something that is obvious for us might not translate into the app without being conversed. And it's vice versa, because we are not very, IT savvy. So it has to, that understanding has to be there from the beginning, where we teach each other and we learn from each other as we go on, and it is this trial and error that will make the app more user friendly, I think, in the end.
I will add something also to that question. So in there, I want to mention, like I saw several healthcare from a recent AI Expo happened in Sri Lanka. So, but the only issue that I saw that they do have everything, but they don't have the validation. And then some people does not understand the what is the usage of AI. They were thinking like they are the plan to give the full decision out of that. So And then some other than the validation, that you have to be careful on the model overfitting. Like you can give like higher accuracies from throughout the models, and you believe on the AI, but you did not do the validation, and then finally it will be like cause a false alarm, and then false negativity will be the crucial one in the health situation. So false alarm will be consume more than time. We are expecting to save time throughout that, but it will be go for a lot of investigation as well as in terms of the health. So therefore, we are planning to, even the model is not high accuracy, we are going to reduce the false negativity in our models. So that is our expectation, and then just need to tell to the other community to focus on that. Other than these are the decision support systems, so keep the boundary. Final thing is the doctor.
I've learned three most important things from our conversation so far. People and humans should be at the topmost priority when building these applications. There must be validation tools, especially when we're dealing with innovation for people. There must be a human looking after looking after what predictions we're sending out there, and that they should be culturally sensitive. They should be driven from a local problem identified. So they're targeting something locally and culturally sensitive and contextual. Thank you so much, Dr. Rasika and Dr. Dineshani, for walking us through your app. We're very excited to see the work that this app will achieve in the future, and I hope that Sri Lanka can benefit from this app a lot. Sri Lanka's population based birth cohort study shows us that it takes a lot to design such a research and involve technology in it, especially to make it deeply rooted in local needs, and also gives us such wide lessons to be followed throughout the region. I think one more important point that you highlighted, Dr. Dineshani, was that there must be multidisciplinary teams when we're thinking of innovation. It can't just be a doctor's team. It can't just be researchers. It has to be a co-learning experience for an app to be successful on a large scale. To our audience, thank you for joining us for this episode of Inside the Project series. This is an initiative by AI-Sarosh. If you'd like to know more about our solution, stay tuned. Stay tuned as we will continue to spotlight projects that are rethinking health, science, and community well-being across South Asia. Thank you for your time.